Hello, this is Christian Ruff. It's a pleasure to talk to you today for the NATF Clot Chronicles video shoot, the ESC 2021 recap. Quite an exciting European Society of Cardiology conference, a lot of great late-breaking science. And I thought I'd share with you some of the highlights that are particularly relevant for our NATF community. Some important studies regarding antiplatelet therapy and coronary disease were presented and published at the European Society of Cardiology. Two had to do with duration of dual antiplatelet therapy. One was Master DAPT, and that was looking at the management of high bleeding risk patients after they received a bioresorbable polymer-coated stent. And they were studying these high-risk bleeding patients whether shorter or longer duration of dual antiplatelet therapy was effective or safe. And they randomized patients who had recently undergone PCI in the last 30 to 44 days into two potential groups. One group stopped DAPT immediately and just continued on single antiplatelet therapy. And then the other, the standard group, continued DAPT for 5 months and then transitioned to single antiplatelet therapy. And the results were pretty interesting, that basically the results were consistent, and that patients who were either on abbreviated DAPT or standard DAPT, that those regimens were similar to each other with regard to net adverse clinical outcomes, which was basically a composite of both ischemic events and bleeding events. So certainly in an all-comers population of patients who had recent percutaneous interventions, a shorter duration of DAPT is certainly reasonable. Now, this stands in contrast, interestingly, to a second study that was presented, the STOP-DAPT-2 ACS study. Now, this is a follow-on study from the original STOP-DAPT-2, which had a similar message to Master DAPT, where they took patients who were a mix of patients who had stable coronary disease or acute coronary syndrome to either 1 month of DAPT followed by clopidogrel monotherapy, or more traditional DAPT for 12 months. And that study basically showed that being on a shorter duration of DAPT was equally as effective and had less bleeding. But the investigators wanted to know whether this was true if you look specifically just in patients who had an acute coronary syndrome. Remember, these are higher risk patients. They just had a clot, they have more activated platelets, and there's more of a concern about potentially stopping DAPT prematurely. And in this study, in contrast to the others, that 1 month of dual antiplatelet therapy followed by clopidogrel in patients with ACS undergoing PCI did not lead to lower rates of cardiovascular and bleeding events compared to 12 months of DAPT. And so I think there's a very important difference in this study, that shorter duration of DAPT failed to achieve non-inferiority for net clinical benefits, probably because these are higher risk patients with ACS soon after their intervention. So I think when you have patients with coronary disease and you're trying to figure out the duration of DAPT, you really have to consider two things. Are they at high bleeding risk? That might sort of favor shorter durations of DAPT. But remember, your patients with ACS are at higher risk. And so they have higher thrombotic events. And if you can, longer durations of DAPT may be better to reduce their ischemic burden. There was also some very exciting data presented regarding atrial fibrillation with patients who also had valvular disease, and one was the ENVISAGE-TAVI AF study, which studied edoxaban versus warfarin following heart valve replacement, particularly TAVI. And we know that edoxaban was compared to warfarin in all types of atrial fibrillation patients in the ENGAGE-AF TIMI 48 trial, which showed edoxaban to be as effective as warfarin in reducing stroke and far safer with respect to serious bleeding, as well as all-cause major bleeding. And in this study, interestingly, edoxaban was non-inferior to warfarin with respect to a composite efficacy outcome of adverse clinical events in patients who had atrial fibrillation but also underwent TAVI. But there was actually more bleeding, which was in contrast to the ENGAGE study, and in particularly GI bleeding. And we know that although the NOACs cause far less serious bleeding than warfarin, we do know that many of the agents have an excess of GI bleeding. And it appears in this population, who were also receiving usually antiplatelet therapy in addition to their anticoagulant, that really exacerbated the GI bleeding, in particular in the edoxaban group. And so I think this is an important study that certainly shows that in patients at very high risk of GI bleeding, the NOACs don't necessarily have a clear safety advantage. Now, shifting gears a little bit, but still in the atrial fibrillation field, we know that obviously anticoagulation is the standard of care for reducing thromboembolic risk, particularly stroke, but there are non-pharmacologic opportunities, and those are left atrial appendage occluder devices. And there was an interesting study, the AMULET IDE, which compared one type of device, the AMULET left atrial appendage occluder, versus the Watchman. And in this study, which was very interesting, that they basically compared these two occluder strategies, and that basically the primary endpoint, which was a composite of ischemic events, mortality, and bleeding, was similar between the two endpoints. And so I think that's important as far as the clinical outcomes, but it wasn't really powered to note a clinical difference. But one of the things that's important when you put in these devices is how well do they seal the left atrial appendage? Are there any gaps that could potentially let a clot out? And when they did this type of imaging, it actually appeared like the AMULET left atrial appendage occluder was superior to the Watchman in achieving complete closure of the left atrial appendage. Now, whether in a larger study that would lead to less strokes or potential even to eliminating the need for anticoagulation in these patients is unknown, but certainly promising that you may get more complete closure of the left atrial appendage, and that could potentially in a larger study lead to a reduction in ischemic stroke. One of the other things I think we've been struggling is how much should we look for atrial fibrillation? We know atrial fibrillation increases the risk of stroke. Wouldn't it be great if we could catch atrial fibrillation earlier and start anticoagulation? And there was an interesting study, the LOOP study, that looked at continuous monitoring. And if they detected atrial fibrillation and patients got started on anticoagulation, could you reduce the risk of stroke? And they randomized over 6,000 patients in Denmark to an implantable loop recorder. And indeed, they identified more atrial fibrillation, 31.8% in the loop recording group, compared to only 12.2% of patients in the standard group. And as would be expected, anticoagulation was initiated more frequently in the monitored group, but it did not translate to a significant reduction in ischemic stroke. Now, there was a non-significant trend, a 20% reduction in both ischemic stroke and all-cause mortality. So I think how I interpret this study is if you look for AF, you'll find it. Whether you start anticoagulation, whether that improves patient outcomes or reduction in stroke is unknown, but there certainly was a signal here, non-significant, but perhaps in a larger study, there may be a potential benefit. But it also gives us caution that the type of atrial fibrillation that you may pick up when you look for it in an asymptomatic patient may not be the same type of atrial fibrillation that we see when a patient shows up with palpitations with clinical atrial fibrillation. Now, let's shift gears to some exciting presentations regarding COVID-19 and the risk of venous thromboembolism. One of the highlights of the ESC was the Michelle study, and that was looking at medically ill patients who were hospitalized for COVID-19 and looking at, we know they're at risk for venous thromboembolism, and looking whether when they're discharged in the hospital, whether extended prophylaxis with rivaroxaban reduced their risk of ischemic events. And I think a very exciting finding, the primary endpoint for this trial, which was symptomatic venous thromboembolism, VT-related death or bilateral VTE, as well as MI and non-hemorrhagic stroke and other limb events, was significantly reduced, only around 3% in the rivaroxaban group compared to over 9% in the control group, with very, very low rates of bleeding, really 0% for major bleeding. And so I think this is a very provocative study that in hospitalized patients who are medically ill, who are at risk for VTE, that extended prophylaxis with rivaroxaban was incredibly beneficial for reducing their risk of thrombotic events. And there are other studies like this also being presented and published, which will help inform whether we should be routinely prophylaxing both inpatient and outpatients who have COVID. I think an incredibly important epidemiologic study was also presented, the SAS study, which was salt substitution study from China. And here in this interesting study, they took 600 rural villages in China, about 21,000 participants, and they randomized them to either a salt substitute or regular salt. And they wanted to show by using a salt substitute that you'd reduce the risk of all sorts of adverse cardiovascular events. And basically they found that major cardiovascular events was indeed reduced with the salt substitute, and including a reduction in all-cause mortality. which was pretty impressive. And so this shows that a simple, cost-effective approach at a large scale could substantially reduce cardiovascular burden. One of the caveats is these salt substitutes can increase the risk of hyperkalemia or an elevated potassium, and there wasn't routine monitoring of that in this study. So that's one thing in sort of additional studies, the safety of it, I think that needs to be looked into with more caution. Another, I think, important landmark study was the IAMI study, which looked at patients who came into the hospital with myocardial infarction or who had PCI, so patients with active coronary disease, and looked whether giving them the influenza vaccine soon after their event improved patient outcomes. And this trial was published in Circulation, and they enrolled over 2,500 patients and then randomized them to the flu vaccine or placebo within 72 hours of their event or hospitalization. And very importantly, there was a substantial reduction in both the rates of the composite outcome, which was a mix of thrombotic events and mortality, but also a significant reduction in all-cause mortality by 41% and cardiovascular death by a similar magnitude. So giving the vaccine, the flu vaccine, to high-risk cardiac patients early after their MI appears to lower their risk of mortality as well as stent thrombosis. So I think that this will be a very important tool in our armamentarium to protect patients, not only focusing on their coronary disease, but we know that if they do happen to get influenza, that can have very serious consequences for someone who is hospitalized for cardiovascular disease. And I think to end on a very provocative study for me as a coffee drinker, there's obviously been intense debate regarding the benefits and risks of caffeine consumption, particularly coffee. And there have been lots of studies looking at coffee drinking, and they've had mixed results. And I think this is one of the best ones that were presented. And this was looking at a very large group of patients from the UK Biobank, approximately 470,000 patients followed for 11 years, subjects, looking at whether coffee consumption was associated with a cardiovascular benefit of risk. And they actually found a very interesting finding that up to 3 cups of coffee is associated with a lower risk of stroke, fatal heart disease in this study. And what's interesting about this study is they had a very important mechanism to do a sub-study where they had a bunch of cardiac MRIs in about 30 or 31,000 of these participants. So they looked not only were there reduction in clinical events, but was there an explanation for this? Was there biological reason why these patients might have cardiovascular protection? And it was interesting that compared to subjects who did not drink coffee, daily consumers of light to moderate coffee consumption had healthier sized and better functioning hearts, which at least gives some biologic plausibility that some amount of coffee drinking may actually be associated with reversing the detrimental effects on aging of the heart. And again, much more work needs to be done. This doesn't prove that coffee drinking is helpful, but I think one of the first large studies that tries to link outcomes with coffee drinking with potential mechanisms. So I'm certainly very relieved by that, considering I am at least a light to moderate coffee drinker myself. So it was delighted that I could share these very exciting late-breaking science for you from the European Society of Cardiology in 2021. And I look forward to sharing some more late-breaking science from future conferences. Thank you.